Good afternoon, everyone. My name is Jackie Leiser. I'm a senior manager with the CAQH core team, and I want to thank you all for joining us this afternoon for our webinar, Prior Authorization Impacts on Patient Access Professionals. We're really excited today to be hosting NAHAM, that's the National Association of Healthcare Access Management, who will share results from their recent prior authorization survey. Michelle Fox, immediate NAHAM past president and director of revenue cycle operations and patient access at Health First, is joining us today to share those results. And Rachel Goldstein, our vice president at CORE, will also help round out that discussion and talk a bit about what CORE has been working on in the prior authorization space. Before we get started, I'm just going to go ahead and share some logistics with you all in the audience related to Zoom. Today's session is being recorded. All attendees and registrants will receive a link to the recording after the presentation. So within the next 1 to 2 business days, we'll be sending out an email with that information. Your microphones will be muted during the webinar, but if you do have a question for either of our speakers today, you can go ahead and submit them at any time throughout the presentation using that Q&A button at the bottom of your screen on your Zoom menu. We'll have time for questions at the end, but again, feel free to submit them as they come to you. Taking a look at our next slide, I'm going to go through the agenda for the next 60 minutes that we have you all. So we'll start off with NAHAM. They'll share a little bit about who they are, and they'll discuss their 2023 prior authorization survey results. Then we'll switch things over to CORE briefly, just to round out the discussion, to share about prior authorization in the industry, the current state of the industry, and a bit about our operating rules and what we're doing in this space. Rachel and Michelle will then have a discussion about what we learned today, and we'll wrap things up with a Q&A with any questions that the audience has at the end. And with that, I'm going to go ahead and pass things over to Michelle. Michelle, if you want to introduce yourself briefly, and we're looking forward to hearing about your survey results.
Thank you, Jacqueline. Hi, I'm Michelle Fox, Director of Revenue Operations and Patient Access at Health First. And I'm also the immediate past president of NAHAM. And I was the chair of our prior authorization task force. And I'm delighted to be able to speak with you all today. Next slide. A little bit about NAHAM. Some of you are probably like, what is NAHAM? I've never heard of NAHAM. So who are we? NAHAM is the National Association of Healthcare Access Management, and we are basically a not-for-profit association for healthcare access professionals. And we have individuals. Our membership is all of hospitals, clinics, ambulatory side, and the acute side. We've got some business partners. We've got technology vendors that are also part of NAHAM, but we really focus on the front end of the revenue cycle. So, you've got your scheduling, your admissions, registration, your patient finance, benefits, coordinations, pretty much everything from pre-arrival till when the patient hits the hospital. And then, once they're discharged, billing and collections, the back end takes over. So that is what NAHAM is. And what we do is we strive to establish best practices and subject matter expert so that we can provide that information for our members. We provide an array of networking, education, certification opportunities. We do the webinars and the educational toolkits. We've got a whole bunch of resources on our website for all patient access professionals that they can access at any time. And then we enable our members to influence and promote high quality delivery of patient access services. We want to help them be the best that they can be. Next slide. So we started a prior authorization task force in 2021, and our main goal was to get our voices heard, basically the membership of NAHAM, and say, we got to get CMS, we got to get people out there, we got to get payers and providers, all on the same page, and let's get our voice, since we had a captured, audience of a couple thousand members of their pain points on prior authorization, and not just, share pain points, but also share solutions, like come together and come up with solutions and recommendations in order to improve the whole administrative burden process on both payers, providers, help with our technology partners to be able to help out. And we want to promote actionable solutions to prior authorizations. So with that, next slide. Some of the things that we accomplished over the past 2-3 years is in 2022, we wrote a white paper optimizing efficiency of prior authorization processes for payers and providers. And that was something that we were able to publish to get the word out there, things that we, suggestions that we had for prior authorization, things that we had thought about, documenting pain points and recommended solutions. In 2022 and 2023, we had a prior authorization roundtable, and which was pretty cool. So we had some NAHAM members. So you had your acute and ambulatory representation providers at the table. We had some payers at the table, and we also had some of our technology vendors that were business partners of NAHAM. We had them at the table that obviously focused in prior authorization management and automating that process as much as possible. And we brought everybody together and we discussed, from everybody's perspective, what are the challenges you're experiencing? What are you seeing? What are ways that you feel that we can solve these solutions, recommendations that we could give to CMS, since they are the front runners on trying to finally tackle and create some efficiencies within prior authorization process. And then one of the things that came out of our prior authorization roundtable was to, let's hear from the members themselves. Let's hear from the hospitals themselves and the ambulatory clinics themselves. And let's validate some of the stuff that we think, is happening out there. And so we were able to get a prior authorization survey from the NAHAM membership in 2023. And that's what I'm going to share with you today, what our results were from that survey. Next slide. So just some of the top points, some of the summary of the findings that we had were that denial rates and reasonings are inconsistent, meaning that, one payer will say it this way, one payer will say it this way. Even the reasonings, it's hard to understand for the providers. And please know, this roundtable and the survey is not anything, it's not, provider against payer or anything like that. This is just simply what, we surveyed the providers. If we survey the payers, you will get their reasoning too. So I didn't want anyone to think that I'm picking on payers, but I'm not. So this is provider based. This is from the NAHAM membership, and these were the survey results from us. So most patient access departments are exploring new ways to address prior authorization. The technology, most of them have technology, some don't, and technology can't cure everything, right? I mean, it can hopefully make things faster. We can leverage it where we need for reducing staffing resources and automating processes. But the prior authorization process is one process that just, it's a struggle to be fully automated. So you got to come up with different ways, how can we get creative on reducing that administrative burden? And then the documentation requirements are becoming more robust. They're asking for more clinicals, more information, more things are going to peer-to-peer. And so we're having to, do things that we hadn't had to do in the past. Next slide. So we were pretty excited. We had about 280 responses received, which if anybody of you have done surveys, it's hard to get people to actually complete them. That represented about 165 organizations. 87 comments were received on our solutions to address prior authorization, 70 of which provided consent and contact information to follow up with so that we could, expand on it in the future should we want to. I do want to point out that we did have a limitation to this survey, 18 duplicate respondents. And that's because when we send it out, you've got some people that are from the same organizations. Like I would have, I'm a patient access director, but one of my patient access managers also took the survey, right? So and having 280 responses and only 18 duplicates, that was pretty good. And then the way that we did this was actually at our national conference last year, because we had immediate access to people and we could say, here's a QR code, take it now, right? Well, when you're not in your organization and you're not at your desk and you don't have access to all of your, reports and stuff, some of the information you can't remember off the top of your head. So we did have some things you'll notice in our survey that people said don't know. And it's because they just didn't have the information with them at the same time. And some of the questions, they were unclear with the organization. Does it mean department? Does it mean my whole organization? Does it mean just patient access department? Just my auth team? So that was a little vague, and we learned that that in the future, we need to be clear about that. So just wanted to be upfront with that. All right, next slide. So the work sites, where then they could select more than one, but these are the different types of facilities that were represented in our survey. You had your academic medical center, your mental behavioral health, long-term, independent, ambulatory rehab. You had your IDNs, your integrated delivery systems. So you had hospital, and then you had multiple hospitals, critical access, and community health clinics. Next slide. How many individuals does the organization employ? So anywhere from 200 or less to over 50,000. Because remember, when you're talking about, hospitals, health systems and stuff, you've got people that are large organizations where they've got hospitals in multiple states, lots of hospitals. So yes, it's easy for them to get up over 50,000 people that they employ. So, and then you have your small, maybe rural hospital, or even a critical access, which only has like maybe 15, 30 beds. So it varies with our membership of NAHAM. Next slide. So this is interesting, and that something that we always like to get when we're surveying patient access is, we're all on different systems. And so the systems can also be they can be helping you, or they can be hindering you, depending on the capabilities and the functionalities. So we like to see what people are on, what systems they are on, because then it also helps us that when we're having an issue, or we got something we want to share that we found out, then it's nice to be able to go to NAHAM member, and for those that are on the same system, to be able to talk and get best practice or process improvement opportunities. So we had, all of them, from Allscripts, Athena, Epic, GE, McKesson, eClinical, Cerner. You guys, can see Meditech, NextGen. And then you also always have other, because there's always another system out there that we don't know about. Next slide. So how many, we want to know about the FTEs that are in their departments. So we wanted to get the information on, who's actually doing this work, and, trying to get cost data to show that the administrative burden does require, staffing and labor costs. So in the access department, that are only devoted to prior authorizations, because we want to focus, that's what this whole survey is on. And you can see it ranges anywhere from, I guess some people don't have prior authorization departments, so they put 0, and then to 25 or more. So, and obviously this just depends on your volume and how large your, how small or larger hospital, clinic, health system, whatever. Next slide. So of the total FTEs devoted to prior authorization in your patient access department, what percentage are non-clinical? And the reason we wanted to find this out is because we want to show that sometimes people are able to, what expertise do you have on your authorization team? And does it require, like, do people that have clinical people on their team, are they more successful in getting the authorizations, or even overturning some, initial denials? So it's pretty interesting that you have 58.7% of the respondents have 100% non-clinical. So that is your, I bet from experience, I bet that's the right off the street. I worked at Lowe's yesterday, and now I'm coming over here to be in a patient access department. So 10.4% non-clinical, and then all the way to a majority are non-clinical, 2.6. So, but that 100% non-clinical was very, I wasn't surprised by that. Next slide. So then we asked, what percentage are clinical? And obviously, if you have, majority are 100% non-clinical, then you're going to have 0 clinical. But it was pretty interesting to see that you do have people that have clinical. And so then after that, when we said, okay, what's clinical? Now the next step is you're going to want to know, well, what kind of expertise are those clinical people? So next slide. So then we asked that, please check all types of clinician that your department employs in this capacity. So it ranges all over: MD, PA, and PRN, LPN, MA, CNA. So all ranges over. In my experience, we have had 2 RNs that we actually had as RNs to do initial appeals for our denials program. That sat with my prior auth team, and so it was nice for them to have access. So they've kind of served a dual purpose. They would work on the initial concurrent reviews to prevent denials for medical necessity on the inpatient side, but they'd also be there to help my prior auth team should they want to talk to a clinical person, or even a peer-to-peer if it didn't have to be the ordering physician, as long as someone could speak the language and help the payer understand what really is the need for this authorization. So it did help. Next slide. So in talking about, authorizations, we have our initial and primary denial rates. And so you can see that it's really all across the board. Majority is the 1 to 3%. I would think that someone who has a pretty good process in place for prior authorization, that's probably the norm. 13% or more, that was interesting. Next slide. This is the percentage of initial and primary denials that get overturned. So they've said, you're not, this doesn't meet, or, you need, for some reason, they need lesser alternative treatments. They are, pain management, they have all these reasons that and steps to go through before they will, authorize, let's just say an MRI or a CT or, any of those high dollar imaging. And so if we can get those, and you go back and say, okay, now you got this, so now you can, move forward with trying to get an authorization approved. And that's all across the board as well. Your 0 to 10% is the highest, which is usually right. Once they do an initial denial, and then you know what to do, then you can go back and fix it. Next slide. So we asked them to please estimate how much patient access department's spending annually on prior authorization. So this includes your full-time employees or part-time, either salaries, benefits, technology, software, really anything that you're having to spend, any expense on capturing that prior authorization. And so this is, keep in mind when you're seeing less than 100,000 or you're seeing more than 5 million, you've got the range of respondents. You've got your small critical access hospital all the way up to you've got your multi-state, health systems. So when you see those numbers, that, it's representative of all that. But it's money. I mean, this process definitely takes money, and it takes money on the provider side and the payer side, because, everything the provider's doing, the staff that's, sending over those authorizations, you got to have on the payer side, they got to have staff that's reviewing them and, approving, denying, whatever. So it's a costly process for everyone involved. Next slide. So we asked, to your knowledge, is your patient access department exploring any new processes or solutions to address aspects of prior authorization? And most of people were planning to implement. The 23.2% no plans to implement a new process. I'd be curious to see what their reasoning is, because if you're doing anything, healthcare related, meaning you're at radiology, cardiology, any of those high-end imaging services, you've got to be dealing with prior authorization. And if they're not, I want to talk to them, because I want to know how they got around it. But most planning, and then 34.3% actually implemented new processes or solutions within the past year. Next slide. So please rate the degree to which you or your patient access department agrees or disagrees with these statements. And so we had patient care is delayed as a result of current PA policies, and most of them, agreed. Initial denials are often approved following appeal and or peer-to-peer meetings. Most of them agreed. Documentation required to obtain PA has increased in the past 2 to 3 years. 81% agreed, or in the top 2 boxes. Denials of PA lack consistency in reasoning. So 63% said agree or strongly agree. And then prior authorization technology is successful in improving the efficiencies of PA. You had 48%. And I think that most, if you don't have technology, not everyone has technology for it. And then if you do have technology, some of the things that I have found, especially within my organization, because we do have technology that helps us with that, is it's not always real time. And so sometimes my staff just going to the payer website or going to their portal, they are able to find things quicker, as well as, sometimes if, interface issues or whatever, the efficiency is not always there. Next slide. So 60% of respondents think that patient care is delayed as a result of current prior authorization policies. Next slide. I apologize. I just went through all this. I forgot that I had a slide for each one of those. But this one with the peer-to-peer and following appeal, that's where some of those clinical people that are part of a team can be involved, or the delay in trying to get things approved is because you do have to have the peer-to-peer where if you don't have a clinical person on your team that can meet that requirement or speak to that, whatever issue it is, obviously you got to wait, get the doctor, the ordering physician involved to talk to the MD or the director at the payer. So that can push things out, even further. Next slide. The documentation requirements. This is the the clinical stuff. When you have an MRI, now we want to know, like I had just mentioned previously, about what are the lesser alternatives that they've tried. Did they try pain management? Did they try PT? So each, depending on the plan, depending on the payer, depending on the service, there's different requirements for documentation. But obviously some people want physician notes from their past visit. So those are things that, you'll see some of our recommendations, about standardization and knowing exactly what information to get so that we can, on the first pass, get that information to the payer to get it approved. Next slide. Denials lack consistency in reasoning. If anyone's dealt with prior authorizations and getting the denials, it's depending really on who you're talking to that day. And payers, CMS trying to, they do one thing, private insurers do one thing. And really for providers, what we'd love to see is that we're able to have one or have like a standardized reasoning with all payers. So I don't know if that will ever happen, but that would be nice. And just like vice versa, the payers, if they have one way that they want information from the providers. So it can work both ways. We want standardization on some of the information that we get back, and then payers could, require standardization on things that they get back. So then we're all on the same page. Next slide. And then talking about technology, which I've covered, and there is technology out there. No one has solved the whole entire process because submitting and then, requiring extra information, and then some payers requiring certain data sets, especially with the 278s and the HL7s and all that jazz. There has not been someone that's got everything set in for prior authorization to solve all of the issues. If they did, they wouldn't be working, right? They'd be on some island enjoying themselves and retired. All right, next slide. So if your patient access department has, we asked them at the end to actually give us comments and share what they've implemented, if they had any new processes or solutions to address prior authorization. Some of them were real-time eligibility, automation, They've established training programs, standardized their workflows, implementation of bots. We all know that the, robotic automation processes as well as the AI, stuff like that is all, out there. And people have been able to use it within the authorization process. Then we formed a denial committee to address problems, pinpoint, and try to find a common issue and work to remedy it. So, that's kind of reactive, but it's a way for some people to tackle the denial issues. Next slide. If you're, so these are just more of the comments that we saw. So we implemented a 72-hour and 48-hour review of pending authorizations prior to date of service for surgical cases to determine root causes and identifying ways to reduce last-minute authorization issues. And they said it had resulted in a 29% reduction in their auth issues. So basically, like I had mentioned before, that they, it's proactive, where you're actually reviewing the pending to see what can we do. And also, so you're able to, I don't like to say cancel, but you're able to reschedule to a later date that service so that, number one, you can get the authorization and the payer, the patient will be covered, the provider will get paid, as well as, since you are rescheduling it to a later date within the 72-hour, 48-hour rule, now you've opened up that spot so that they can put another patient in there that hopefully already has the authorization and they'll get paid. And so it's good for the organization as well. So if you've got capacity, you don't want, your ORs and your machines sitting idle. So that is we actually do that at our organization too. We have recently taken advantage of all predetermination opportunities with insurance companies to try and avoid any possible denials. Definitely, working with the payers on knowing what they're doing and then being able to do it with the predetermination. So this organization has actually taken an extra step where they are probably doing 100% predeterminations, which is not required, but it's good to know ahead of time. Then we use an auth automation tool, 61% auto approval rate. They've added bot technology and HL7 to bring in the diagnosis and CPT code information from the orders. So it actually is doing it whatever is a redundant, it doesn't vary, it has no variance in the process. They're taking literally probably screen scraping and taking information from the system and just taking it and putting in. The bot will do that. Obviously if there's any critical thinking or reasoning, a bot can't do that, but anything that's just a structured, consistent and redundant process, the bots are really good for. And they saw a 50% reduction in final write-offs after implementing the tools, auth matrix, and new department workflows. Another organization said automation reduced FTEs by 13, improved timeliness of auth and decreased rescheduled patients. We all know that if you leverage technology, it can do things that your staff can do. And, you don't always have to lay them off, but now you're able to use that staff through, reallocate them to other purposes. So, because we all know with the staffing challenges, especially in patient access, we do have staffing challenges. And so it's nice to be able to leverage technology and then be able to repurpose that staff. Next slide. So those are the results of our prior authorization task force survey that we did with the NAHAM membership. And now I'm going to hand it over to Rachel to talk about the core prior authorization overview.
Thank you, Michelle. I'm just coming on video here. That was super interesting. And given a lot of the work that we've done in this space, so much of our environmental scanning efforts and research, a lot of the same themes were really highlighted in what you've presented here. And I think wherever we can have more data from industry to back up what the organization is seeing and feeling and thinking, that hard data is super important. So just big shout out to your organization for putting this together and bringing it to us and our audience today. So if we could move to the next slide, I am going to get into what CAQH core offers in the prior authorization space and the work we've done, but just quickly before we get into that, in case there's folks on the line who aren't too familiar with the work that core does in industry, I will provide a very brief overview here. So we're really a multi-stakeholder organization that is consensus-based, and we have a mission to develop operating rules to improve the exchange of information in healthcare, including prior authorization. And operating rules, which is really kind of the key output that we drive, though we do have other areas I'll touch on in a moment, are essentially business rules that define and improve interoperability between trading partners. These rules build on top of, but do not duplicate existing standards. So we're designated by the Secretary of Health and Human Services as the National Operating Rule Authoring Entity. And this really spans the patient access and revenue cycle continuum. So everything from when a patient encounter is being scheduled to provider submitting a claim, adjudication, payment, and even management of health plan membership. So it really runs the gamut here. And we have an arm of our organization called Insights that does quite a bit of research in this space and measurement and runs numbers. And essentially, we have an annual index report that really benchmarks where industry is at in terms of transitioning from a much more manual model of exchanging information and doing healthcare transactions to a more automated one. The index estimated that there's about 18 billion in potential savings if we were to really fully transition from a more manual model into a fully automated model. And operating rules help us really get towards that full ideal savings. So 10 of our operating rules to date are actually federally mandated. But we also have voluntary adoption of some of our other operating rules, and many organizations do choose to implement both the mandated and voluntary because of the return on investment that's really associated with exchanging healthcare information in a more standard way. So if we could move to the next slide. Moving into prior authorization specifically, I did just speak about the annual index survey. And here you see a snapshot really of where prior authorization is at. And we do have this for all of the revenue cycle transactions within our index if you're interested to see more, and we put this out annually. But for prior authorization specifically, really historically has been one of the lowest adopted electronic standards for information exchange. I mean, many of the pain points that you just heard from Michelle are the key reasons why this is such a difficult and dynamic thing to address. It's not really as simple as just, other parts of the revenue cycle that may be simpler to solve and may be more adopted in automated format. Prior authorization is a huge time and cost suck for industry. And given this major issue, we've seen significant momentum in the past several years to address this head on and really even mandate the use of electronic exchange, which is what we've seen with the final rule that's come out from CMS for interoperability and prior authorization, which we'll touch on in a moment. If we can move to the next slide, please. So CORE has really been historically engaged in prior authorization for quite some time now. We've done a tremendous amount of research and work in terms of bringing industry organizations together to succinctly define pain points and articulate and really define areas for standardization that may even expand or exceed what standards are able to do. So really kind of what are those business rules that can fill in some of the potential gaps where additional standardization could really come into play and take everything to the next level here. So we really have a significant amount of research and environmental scanning that we've done. And through that, we create small advisory groups that have significant stakeholder interviews at play. And we create these advisory groups to basically pressure test potential business rules and solutions to plug holes into some of these gaps that we're seeing. And then through the industry feedback and advisory groups, we also create new and updated operating rules that bridge the gap and support that implementation of electronic standards. Just for example, a couple that I'll highlight that I think are really relevant today are operating rules that support attachments or additional clinical documentation for the prior authorization transaction. This is things that specify, common hangups like optimized response times and file size and standard error code reporting. So this is really something that helps minimize that back and forth conversational nature that can really play out and turn, what should be maybe even hours of response time turnaround into days and days and days. Another one that we have is a connectivity rule that establishes security authentication and connectivity requirements specifically, and it specifically does apply to prior authorization and our other transactions. We have other best practice rules that we've developed in this space as well. And finally, we offer measurement services that assist implementing organizations with tracking and monitoring essentially their return on investment to implement standards and operating rules. A lot goes into this, and even, what it takes to get a group of like-minded people together in your organization, decide that you're going to implement, and then go that mile, really take it through to the end. There's a lot of reporting that needs to happen. And oftentimes you really need to be able to articulate what the value of that implementation is going to be to cross that kind of stage gate business case and get going. And so with our insights arm of our organization that runs that annual index report, we partner and we work with organizations to essentially provide that service. If we could move to the next slide. So one thing that I did just want to give a small preview on, and then we'll probably jump into the discussion portion and open it up for questions. But we do have a forthcoming paper coming out. There's a ton of talk right now in industry about the final rule from CMS on interoperability and prior authorization. And we have a white paper coming out that really breaks down that rule in a very digestible way for implementers. So it's a great educational overview as it relates to the prior auth requirements within the rule, and makes recommendations on really how to get the best bang for your buck out of the mandate and the implementation within your organization. So for folks on the line that actually are sitting within organizations that know they need to be implementing this rule and are looking towards that 2027 deadline, really the thinking around it starts now or yesterday, and CAQH and CORE can really serve as, really help provide guidance on that and how to think about this implementation and how to get started. So we'll make sure that everyone on the line gets a copy of that paper. We're looking forward to putting it out. And then I also do want to offer and just specifically mention within this context that we do really recommend that organizations work on their implementations of the final rule with a partner like CAQH to track and measure the success of your project. And that can really also feed back into feedback to CMS, and the office that works on this rule is incredibly, and kudos to them, hats off, they're very open to hearing recommendations. How is the implementation going? How can we iterate on the rule moving forward? What can be included in future rulemaking that we may not have, maybe they didn't include before. And so really tracking that and having an organization like CAQH partner with you to synthesize that information, I think can be very valuable. So I did just want to offer that up to this audience given our topic today. And with that, I think we can move on to some discussion questions. I do have some questions for you, Michelle, and then we'll open it up to some questions from the audience. So, Michelle, one thing I do want to ask you is, you have so much data, it's also valuable, but for you, especially as somebody who's working in this field day in, day out and feels these challenges, were there any particular aha moments for you, maybe during your roundtable?
Well, good question. There were some aha moments because we were able to actually bring payers to the table I think that we were able to share, I think we all walked away with some aha moments, but one of the things that resonated with me is that I didn't realize that the payers were not always the ones making the decisions. And that, payers are employers, right? Employer groups go to payers and say, hey, we want you to cover, our employees and offer the insurance and everything. But the payer really is the one, the HR departments, they're really the ones that are dictating what's going to be covered and what's not going to be covered and what percentage is going to be covered. And yes, we want to, we want to allow this service, but we don't want to allow this service. And that, I mean, for a couple of us providers that were at the round table, I mean, our eyes were open. We're like, what do you mean the employers are the ones that are making those decisions? Right? And so really, as providers, it really said, oh, well, we need to go back and we need to talk to our HR departments and we need to see what restrictions are they putting on that the insurance and the payers, they're really like kind of right? They're just like a TPA kind of where they're just administering what the employer has agreed upon, what restrictions they put in place. So that was really eye-opening, saying that, oh my gosh, so really, if we want to, say, why does this require prior authorization? Go back to the employer and say, why are you requiring prior authorization on this, right? So that was an eye-opener for some of us, as well as the payer contracts, when you are talking and when it's time to renew, and you're, in patient access department, or if you're keeping track of, these services, always require authorization, or this one code always requires authorization with this plan. So at time of renewal, go back, be basically partner with your managed care department and be at the table when you are renewing the contract. So you can talk with the payer and try to get maybe in your contract of, you always authorize this at 90%, like 90% of the time this is authorized. So maybe we don't have to have that authorized anymore. Maybe we can skip that, right? Based on if it has this diagnosis and it has this, for this procedure, you don't need that authorization because that's always going to approve at 100%. So just really taking the time to go through your authorizations, whether it's your denials, your pendings and your approvals, and taking that information and actually taking, using it for the good to improve on the process, and eliminate some of that restriction, or I call it friction, that we don't, it's unnecessary, but no one's ever gone to the table. And sometimes, you don't get what you want because you just simply never ask, right? See, what did it hurt? I mean, the only thing they can do is say no, and at least you tried, right? So those are some
Oh,
things that
absolutely.
when we walked away, just having the payers at the table with us, it was really interesting to learn, to see from their side, some things that, we don't know their world, they don't know our world. And so it was really nice to be able to share that and know that, oh, well, some of the things that we think the payers restricting, it has nothing to do with the payer. They're just doing what the employer had asked. So it's pretty neat.
Yeah, and that brings a whole other layer of variability, right? Because it's like, it's not just the payer bringing the variability of, this payer wants this, that payer wants that payer has this requirement, this payer has that requirement. It's even within a payer, depending on the employee sponsored group.
Exactly.
So that is a whole other level of challenge, but
That's
I
another
love the way
webinar.
yeah, I love the way you're thinking about it in terms of negotiation and coming to it with the power of information and data. I mean, I think the more you track here, the better, right? Because then you're armed with information to be able to negotiate. And instead of just anecdotal, burden stories, it's more like, hey, this was approved at 95%. How about we just drop it next year?
Yeah, because we all know we love it when our, someone on our team comes to us and says, this happens all the time. Really? Okay, we'll start bringing me examples. And then it's like in 1 week, you have one example. It's like, that's not all the time.
Yes, yes. And I do think often plans and providers are pitted against each other as wanting completely different things. It's really interesting when, and I'm sure that I haven't looked at who's listening into the webinar today, but I'm sure we have plenty of people on the line who have participated in our work group efforts on prior authorization. It's really interesting actually how much the interests do align in many ways. Of course, there are spaces where they don't, and that's business, and that's one of the reasons why like healthcare is the way it is, right?
Yeah.
Someone needs to be thinking about these things, but there's so many spaces where providers and payers actually do have a lot of alignment on wanting to reduce that friction. So I think that's a very positive thing to come out of these types of efforts.
Yes, I agree.
So I guess from your perspective, given the CMS final rule and prior authorization and all that it entails, do you have any guidance for providers that may be on the line or listening to this webinar later on how to best prepare to implement the rule?
Well, first of all, we are very excited about this because then it will, faster turnaround times, that we can be more consistent processes. We can get our patients in information to them quicker. And then we also won't have to schedule out, for some of our payers that we know are going to be 14 days or, 30 days, 7 days, whatever it is. We actually have to say, okay, well, if your payer is this, we've got to schedule you out 14 days. And, we don't like saying that to patients. I mean, the patient, you want to provide, good customer service. You want to get them in as quickly, get them quick access to care that they need. So we're really excited about the lessened days turnaround time. But for health systems, on the provider side, that we are going to need to ensure that we're prepared from an infrastructure and technology perspective to be able to exchange that information regarding prior authorization requests via the FHIR and APIs. So this will require planning to be ready by 2027 implementation deadline. And if we don't have this set up, we won't be able to benefit from the process improvements towards the data exchange. It's all trying to, make it seamless. Well, at least that's what the final rule promises, but I have high hopes. And then the best first step is to find the people within your organization that are in charge of this, that you can, rally up. You have to, all the folks that are with the impacted departments, assume the current state and any changes required to meet the future state. Start planning now, develop the roadmap with the, and make sure definitely that you have executive buy-in.
Absolutely. I think that executive buy-in piece is super important, right? You need a leader, you need that agency, right? You need the person that's gonna rally for you and make, basically essentially protect the work and make sure it's getting done. Yeah. So I guess one more question for you, and then maybe we can open it up to the audience for questions. But what do you feel that the cost is for patients that don't seek the necessary care or the care that they're looking for because of prior auth denials?
Well, so number one, I mean, most patients aren't getting stuff done because they just want to get stuff done. I mean, I don't just want to go have an MRI of my, if you've ever had an MRI and how loud it is, you don't want to just go do it just for fun. So obviously there's a need for it. There's medical necessity for it. And the cost to them is that they delay the service that they really need. And then some you've seen where then they end up in our emergency rooms and, it's catastrophic because they let it go too far. And then, that's a higher cost for them sometimes. And just them needing more care because it wasn't taken care of timely or, being proactive. So I believe that, I mean, the cost to them is number one, the demise in their health, as well as some of them will choose to be self-pay because they want to make sure that they get it done because they feel that the doctor has said it. A lot of people take what their doctor says and that's gold. And my doctor says I have to have it. So you know what, I'm going to do it. And we've seen, it's sad that some patients will have to go that route and they'll be self-pay and then they, have to, they can't afford it. Some are on fixed incomes. And so then you have to go through the whole financial assistance. It's a whole process. I mean, they've got insurance, they want to use it. So, whatever we can do to help them to be able to hopefully get the authorization. That's what we want to do. Let them maximize their benefits of the insurance that they're paying for. And then we don't have to go down that other ugly road.
Yeah, absolutely. Well, thank you so much, Michelle. That was really interesting. We really appreciate your input and expertise here.
Absolutely.
Jackie, should we open it up to the audience for any questions they may have for me or Michelle or in general?
Yeah, that sounds great. Thank you to those of you who submitted questions. And if you still have a question for our speakers after that really nice discussion, please feel free to submit them now as well using that Q&A button at the bottom of your screen. But yeah, I'll kick things off with a few questions that came in as you two were chatting. The first is, do you expect the changes required by the interoperability rule for PA management to substantially improve the prior auth process? And if not, do you have any thoughts about what might be missing?
Sure. Michelle, do you want me to go first and then you can?
Sure.
Okay, perfect. I feel very optimistic about the requirements that have been outlined in the prior authorization final rule. There was a lot of rounds of feedback and a lot of work that's been done at the industry work group level to get to those requirements. So I do feel very optimistic. I think with any big mess in healthcare, phased implementation is important and iterative feedback is important and consistent. Like it's not just going to be a one and done, right? And I think even the authors of the rule would say that. Like I think I'm optimistic about it being different and getting us to a new place of success when it comes to prior authorization, but prior authorization is so inherently messy and disjointed that it's going to take a lot. It's going to take implementation to a T, and it's going to take even potential additional things outside of what's just mandated in the rule. And so we'll see how it plays out with the implementation. And I think that's in large part where CAQH's recommendation is coming from, to really work with a partner organization such as CAQH Core to measure the implementation at your organization, have consistent metrics on what success looks like, and to organize and really synthesize feedback on what could be improved. Just an example of something that I think that could, bring this to the next level is something as simple or well, I shouldn't say simple, because if it were simple, it would already be in the rule. But I'm going to anchor back to something that Michelle shared with us, that one of the key challenges that, her and her colleagues are facing are around how not standard denial reasons are, right? So it's like every payer has a different set of denial reasons, or even kind of like error codes or pen codes on why a prior authorization is being held up. And standards do exist for these codes. I mean, it's not like there isn't, there's a lot of proprietary code sets out there that are used probably even more frequently than standards, to be honest, which is sad. But there are existing standards for denial reason codes. And I think that if we can get industry to really rally around how and when to use which codes, so scenarios for when a certain code is used, I think that could be really, really helpful. But again, I think we need to observe these implementations. We need real-time feedback from implementers and, continue to iterate and improve moving forward.
Yeah, I agree with you 100%. My only thing to add is that it's a start. So, and I think that if you're working on decreasing the number of days, and returning, enforcing that the decisions are made quicker, and giving the payer or giving the provider, more time to take care of the patient, it can only help, I believe. And then, usually when you have CMS puts in a rule, then, you have your private insurers that will watch it for a little bit, and then hopefully, some of them choose to go down that road as well. So hopefully, I'm hopeful that we can get to standardization. Standardization and automation are the two things that I think are seriously lacking in the prior authorization. And if we can, tackle those two, then I think we'll remove most of the friction.
Great. Thank you both. Another question that came in during your discussion about tools that are currently being used by different organizations for prior auth. Someone was asking, are there common tools that organizations are using, or are they pretty variable?
Yeah, I'm not. So I think there's a lot of different ways to interpret the word tool. There's technology, there are standards, there are implementation guides. Since this is, we're an organization that works on standards and operating rules, I will, or works in the standards and operating rules space, I'll focus more on tools from a standards perspective. And then Michelle, if you want to share any, maybe like common technology you've seen. But, you know, specifically for the final rule that came out around prior authorization, there are some very specific implementation guides that are being strongly recommended for use by CMS and industry for implementing various aspects of the final rule for prior authorization. And CAQH4 is very supportive of this. We feel like these implementation guides, as much as possible, really need to be leveraged to implement the rule. And so, like I mentioned in the paper that's forthcoming, we'll be, you know, briefly summarizing these, providing links, etc. But if you go onto the CMS interoperability website, they have really, really nice resources on there that define these particular implementation guides. There are 3 that are most critical to the implementation of the prior authorization support. And so, you know, we'd be happy to point you to those resources, but we think that, you know, those are essentially going to be the most common, as they should be, for this particular rule mandate implementation. Michelle, is there anything you wanted to add?
On the provider side, as far as authorization management tools, there's no common, that you've got lots of vendors that are out there. And I mean, it's a hot topic. It's been a hot topic for years. So, you know, they're all jumping in, and there are some that are better than others. Absolutely. And some do more than others. But as far as a common one, not really.
Great, thanks. Rachel, I think we have time for one more question that's for you that we got during registration. Is there any talk of regulating payer websites for them all to work in a similar way in order to ease provider staff burden of navigating many different websites?
Yeah, that's a big one. And I know we talked about that a little bit, that Michelle was saying there's so much variation, and sometimes it's frustrating, and it's almost even easier to just like go onto the website and see what the you know, what's listed on there, but it's incredibly time consuming, right? And so I think one of the big benefits of the prior authorization FHIR APIs that are included in the CMS final rule is that, like I said, there's kind of like 3 main parts to the process, and there's different implementation guides for each. But I'll talk about the first 2 for a moment, and how I think that they could potentially even kind of overtake this whole like payer website situation in terms of looking up requirements. So the first one is the coverage requirements discovery implementation guide. And this essentially serves as trying to understand if the prior authorization required or not. And if so, what's required as information that you would need to include in your prior authorization request. So I think being able to actually have access at your fingertips to that through an API and streamlined information exchange in a consistent way with each payer, that's major. So you know, that would save you from actually having to figure out even where the website is, right? Like, okay, maybe it's Humana, maybe it's a Blue, but like, where's the particular web page on the prior auth requirement, right? That's a whole rabbit hole. So that would be really, really helpful, and something we're looking forward to as a nice implementation of that implementation guide. And then there's also potential with the second implementation guide that's being recommended, which is the documents, templates, and rules. It's called DTR, and this comes after the coverage requirements discovery. There's almost like this the way you can essentially use information to populate the prior authorization request to a payer more dynamically if you've implemented specifically to this implementation guide. And so because we know not only is a prior auth required varies drastically by payer, but what is required to submit in your request to get it approved varies drastically by payer. Again, this would be a huge time saver to be able to dynamically pull information from the EHR to populate a request via, you know, if the payer has implemented and the provider has implemented this particular implementation guide through the FHIR implementation. So, you know, we really, really recommend that these industry implementation guides be used, because the more standard, the better. And there's a lot of really, really interesting, good, streamlined processes that can be taken. So I think hopefully that will reduce the website burden.
Absolutely. Thanks, Rachel. And I know we're just at time. It's 3 p.m. Michelle, did you have anything you wanted to add before we wrap up?
Nope.
Okay.
I'm good. Thank
Sounds
you.
good. Just taking a look at our next slide quickly. This is where you can find us in the upcoming months. We have another webinar scheduled at the end of June with X12 about the 835 transaction. And we'll be scheduling some more webinars throughout the summer. So just stay up to date with our core education series page. CAQH has a few presentations at WEDI this week. It's a virtual conference. So if you're attending, please keep a lookout for our sessions. We hope to see you there. And we'll also be presenting at HFMA later in June in Las Vegas. So if you're attending that conference, please feel free to pop over and say hi. With that, thank you all so much for joining us. If you do have any additional questions, our team is always happy to help answer them at core@caqh.org. And I hope you all have a great rest of your afternoon. Thanks, everyone.
Thanks so much. Take care.
Thank you.
Thanks, Michelle.